Good afternoon. So you're awake, we hope. So first I want to thank you for having me here. I really greeted this event with quite a bit of excitement because of the goals that you espouse, the goals that you have. When you were talking this morning about being best as the way to be first, from the patient's perspective, we would wish that that's what healthcare was always about. But for many, many healthcare organizations, that's a 180, to think about being best as the way to being first, because it's all been about volume before. And so, really, I'm deeply appreciative of the opportunity to be here with you, given the approach that you're taking. I want you to think for a minute, before we start, about service innovation. Service innovation generally. Healthcare is a service, so think about service innovation. Remember what your phone service was like 15 years ago? Are you old enough to have headphones 15 years ago? Most of you are. So, but the phone was on your kitchen counter. And if it rang when you weren't there, tough, it went to the answering machine. And maybe you checked that on Fridays. But really, it wasn't very convenient. Now your phone does your banking, it's your boarding pass, it's your camera, it's your flashlight, hails your taxi. It does everything. There's this whole ecosystem of new services that come in the form of your smartphone. This isn't a smartphone. So imagine if healthcare delivery service had those rates of innovation and adoption and diffusion. We could be, in 15 years, living in a really, really different world if we had that. But that takes a whole ecosystem of innovation, right? It's not just the phone. It's all those apps and the imagination about what you can do with them and what it would be like to have things be more convenient and work better. And it always amazes me that we don't already have that innovation dynamic in healthcare. I mean, think about what's at stake. Quality of life, dignity of death. Could it be more important? And it's not like we don't get it. In healthcare, everybody has a story. You do, or you have a close friend or family member who does, and they're the stories that define our lives. Of course, I do. I mean, how else would you get from engineering to business school to medicine, right? I mean, there's got to be a story there. And there is. There are two huge ones in the form of my sons. My first son was born with a heart anomaly that at the time was often considered inconsistent with life. He's a junior at Harvard now. He's doing fine. But Mike Porter, who was my mentor at the time, did the legwork to find a surgeon who saved quality of life, not just existence. And that's the basis of a lifelong friendship. And then my younger son, who should have had it easy, turned out to be chronically ill. And for 6 years, we had either no diagnosis or the wrong diagnosis at any given point in time. When the diagnosis is wrong, everything you do is waste or harm. And we're not very good at diagnosis, really. Anyway, got to the right diagnosis. He was functionally well within a week and completely well within a year. He's studying electrical engineering at Stanford now. He's fine. He's a really good ballroom dancer. But from those stories, when my younger son got well and I suddenly had 2 well kids, I had a whole different energy for work and for change, and just a million puzzles about why the healthcare system could be the way it is and why we hadn't solved some of the problems that were there. But I came into healthcare and I dragged Mike Porter into healthcare, not because we thought we had an answer, but because there were questions that I just couldn't let go. I just couldn't let go. And you think about it, when the diagnosis is wrong, when the treatment isn't working, when you have a child who's in pain 365 days a year for 6 years running, You're being held underwater in this awful circumstance. If he gets well and you're suddenly up for air, the first thing you do is gasp, and the second thing you do is scream. And the good news and the bad news is I can scream for 400 pages. And I did. So that's the story behind redefining healthcare. And really thinking about what would it be like if the whole system were focused around improving the outcomes for patients, improving the value for patients. What if that's what was the first job in everybody's mind, being best in creating value for patients? So now we have this strategic shift going on from strategy based on volume to strategy based on value. And I'll tell you, I'm still just shocked and amazed that that's happening, deeply grateful to companies that actually have that as their goal, of improving outcomes, being best, figuring out what patients really need. Because when we first were getting ready to publish Redefining Healthcare, Harvard Business Press told us that we couldn't use that value-based phrase on the cover because it wasn't used in healthcare and nobody would read it. And Mike Porter kind of going, we just wrote 400 pages on value. Either everybody will be talking about this soon or it doesn't matter what's on the cover of this book. They let us put it on there. But now the conversation is value. And here's the easiest way to explain what the difference that means. Traditionally, when you're focused on volume, healthcare is spelled as one word and it means treatment. But patients and families want more health. They don't really want more treatment. I mean, I know you guys understand that because less invasive surgery is completely aligned with that, right? So I know that you understand it. But generally, people have thought historically that people actually wanted more treatment. We could test this. Anybody want to spend the weekend in the hospital just for the fun? Catch a few things? Get an infection or two? No? How about this? How about for free an extra colonoscopy? You don't want more health care, right? You want more health. And so treatment is an intermediate good. You'd rather use less treatment to get to more health. And actually, that's the essence of coming up with less invasive ways of doing things, or coming up with ways so that kids have one surgery and then a bunch of outpatient visits rather than spending their childhood investigating the internal workings of a hospital room. So really, it's not one word, it's two. It's health and it's care. And they're both really important, but it's not just treatment. So when we think about value, what we're thinking about is the health outcomes achieved for the money spent, right? What does it cost to achieve those outcomes? When I was working on this, when my youngest son was little, he was about 9, he'd just gotten well. And when he came up and asked me about it, I was trying to explain to him what I meant by this. And he said, Mom, what was the goal before this? And I said, well, everybody was focused on cost reduction, as you said. And he kind of looked at me and he said, gosh, if the goal were cost reduction, when I showed up for care, they could just shoot me. Out of the mouth of babes, right? Clearly, the goal is not just cost reductions. It's the outcomes you achieve for the money spent, not just how to spend less money. And those outcomes are multidimensional, and they occur over the whole cycle of care. And then you also need to think about the costs over the whole continuum of care. And what that means is that this isn't a standard equation. You're not looking for that value number. You're actually looking at outcomes in a multidimensional way. So this chart is ICHOM, the International Consortium for Health Outcome Measurements, measures outcome measures for back pain. And the point is that it's multidimensional and it's essentially from the patient's perspective. So it's looking at not only complications or need for reoperation, but are you in pain? Do you need pain medication? Can you go to work? Or, are you facing disability? These are multiple dimensions of outcomes, and you can't just add them up. And just quality of life is too vague. You need to think about what are the actual outcomes that patients experience. And so what happens is when you're looking at this, you're not looking at a number, you're looking at a radar chart or a spider chart that says these are the different functional outcomes or the different medical outcomes that patients face. And on this chart, I also added cost. Lower cost would be a out, higher number. It's the inverse, so that everything gets better as you go out. But the way we're measuring outcomes now and the way the surgeons are increasingly measuring outcomes means that they're not going to collapse it to a number. They're going to be thinking in terms of multiple dimensions of outcomes for patients. But that's not the way we've been measuring outcomes traditionally or measuring healthcare traditionally. We've traditionally had this whole sort of landscape of measures, and we tend to focus on processes. But come on, tell me any other business, except maybe education, tell me any other business where we measure only the inputs and not the outputs. I mean, traditionally in healthcare, we've measured the inputs and just presumed that the outputs, the outcomes, were pretty much the same. But what we really need to focus on is thinking about what really are the outcomes. And these are the outcomes both during care and as a result of care. And if you think about it, not just in spine, but if you think about healthcare in general, if you think about chronic disease, which is driving 85% of spending, they say, some say 75%, but it's still a big number. Chronic disease lasts for the rest of your life. So the outcomes during care are the outcomes that define quality of life and dignity of death. And if you think about cancer or other prolonged diseases, outcomes during care are really important. So we'll come back to that. But the transformation, as obvious as it sounds, we ought to be focused around improving value for patients. We ought to be thinking about health outcomes, not just about cost. As obvious as it sounds, it's tricky because we have a self-reinforcing system that's about volume. And so changing to a system that's about value requires change at lots of points. It's a hard shift for the system to make. In healthcare, when you think about value, it's created at the level of the individual patient. And that reality is part of what's created the trap that we're in now about how hard it is to change the mindset. It's true. When you think about value, it's about improving the health of individuals. And when people talk about population health, the only way a population gets healthier is if a whole bunch of individuals in that population get healthier. I mean, even at the population health level, this is true. What that means is not that we have to customize care for everybody who comes in the door. It means that we need to organize to deliver solutions for patient segments that have similar needs. Okay, that sounds really, really obvious, but here's the problem. This is how we're organized now. So if you were a patient with diabetes, I hope you're not, I hope you never are, but if you were, this is what you'd face. You'd face all these different services. They're organized around the supply, so they're organized around the providers or the labs or the doctors and their specialties, and you have to somehow coordinate, organize, and get to all these appointments in the right order at the right time with the right information. It's darn near impossible. And then we wonder why people are non-adherent. Good luck. The problem is that we're organized so that we can treat any possible person who walks in the door. You know, from this array of services, we can construct what you need and what anybody who walks in the door needs. The problem is we then end up doing most care really inefficiently, because even the things that we see over and over and over again, we customize when they come in the door rather than having really well-developed, smooth, excellent processes and standing teams to help with those situations. So we're not organized for excellence. We're not organized for efficiency. We're organized for access, but ironically, it's so expensive that it undermines access, and then it raises the question, access to what? Below average results? That's not what you want access to. So let me give you an example of how the transformation works. I'm going to use an example from Germany, and this is care for serious headaches. I don't suffer from migraines, but if you do, you would know that they can be completely disabling. This is not a headache in the standard form. This is disabling, can't deal with light, can't deal with sound, can't go to work, can't talk to your spouse, can't function. And so traditionally in Germany, this was organized just the way care is organized in the US, by the sort of parts and pieces. And most patients weren't getting effective or appropriate care for migraine. And so the reorganization changed it so that on the first visit to this provider, the patient saw a neurologist, a psychologist, and a physical therapist so that they could get a correct diagnosis on visit 1 and figure out in a sort of triage process which basic care path they needed to be in so they could get to effective care for their root cause diagnosis very, very fast, rather than it taking months. You usually get to that point on visit 1. So over the course of the first year, actually less than the first year, they were able to demonstrate that for these patients had dramatically reduced pain and increased days at work. So for example, they went from, when they started, 57% of their patients were missing 6 or more days of work for a single migraine episode. And after 6 months, they were down to 11%. It's a lot of pain reduction. It's a lot of productivity improvement. A lot more days at work. And by the end of the first year, they were able to demonstrate that they'd reduce cost of care. More people were seeking migraine care, so it wasn't that they were spending less on migraines. And they were doing more for people who had migraines. It wasn't that the migraine care itself was less expensive, because they were getting the appropriate drugs and the appropriate services. But what was going on was, when you looked at the overall cost of care for those patients, it was down by 25%, because they weren't developing other comorbidities and other problems. If you think about it, if you're suddenly well enough to exercise, go to work, talk to your spouse, eat right, rather than suffering from migraines and curling up in the dark, you're going to be healthier overall. And so the health plan funding this was able to demonstrate a 25% reduction in costs in the space of a year. For all the times people say, well, we can focus on outcomes, but it's going to take us years and years to improve that we've changed the path. Even in diabetes care and the projects we're doing, I've never seen it take more than 14 months for somebody to be able to really document that they're changing the path. This worked in part, too, because they moved to bundled payment at the same time, so that the team delivering this care was able to share in the efficiencies that it created. And bundled payment makes a really big difference in terms of aligning the incentives with medical success. Traditionally in healthcare success and financial success are completely separate and different. You could make a lot of money by doing things to people that didn't actually help. You could lose money doing things to people that did actually help. They weren't aligned. But what bundled payment does is pay the team that's providing the care for the whole bundle. And then it's up to the team, not some hospital administrator, which devices they're using, which drugs they're using, what the care path is, and how they pursue that. But that makes it so that, unlike the Dilbert cartoon this morning, it makes it so that the things that you're being judged on, the things that your performance is judged on, are things that are right there within your span of control. And that's an important benefit. To this. But you can't just paste bundled payment across the top and assume that that'll fix stuff. If there were one right payment model, then we would see it someplace in the world. And we would see this magical, perfect healthcare system. There isn't a silver bullet on payment. And we can't just put in place bundled payment without actually having care delivery transformation underneath it. It's interesting, when I work around the world, every country has at least 2 or 3 payment systems. We have even more than that, but every country has several. None of them have, as a result of their payment system, care delivery that measures outcomes and delivers has teams delivering continuous care that's continuously improving outcomes, because the payment system alone isn't enough. There isn't a silver bullet. And if you think about it now, as we're moving to payment reform, there's a whole bunch of stuff that's going to happen underneath the payment reform in order for it to really, really succeed. And these are things that you're working on. So I'm going to run it this way so you can see. So as you move to prepayment or capitation, right, when there's a lot of movement toward that now, but that alone doesn't fix the problem. And in fact, if you gather together a bunch of people, and we've actually done this, gather together a bunch of people who are leaders in organizations that have been paid by capitation for a long time. They're integrated payer-provider systems, and their payment is by capitation. We gathered 6 of the ones that you would know and recognize. Out of the 6, 1 had significant internal payments that were different than fee-for-service. 5 of the 6 had all the payment internal, essentially fee-for-service. Okay, there is a recipe for a pressure cooker, right? Pay everybody inside on fee-for-service and then slam on the capitation lid and hope it works. It doesn't work. So inside, you need to have payment that's consistent with that capitation view, which means you have to have teams inside that have incentives to deliver excellent care at the lowest possible cost. And you have to have them be able to share in the benefits of doing that. So that's bundled payment that has to come within those organizations, or for the acute care that ACOs are contracting for on the outside. But if you're going to do bundled payment, then you need to have teams, real teams. Every doctor will tell you that they work in a team now, and every nurse, but they work in groups. They don't actually have the team dynamic of learning together as a team and being accountable as a team and measuring their results together as a team and learning together that way. So to have the bundled payment work, you really need to have teams in place. You'll hear more about this, I think, later this afternoon, but you have to have teams in place. Those teams need to be measuring their results. They need to be measuring outcomes and costs so they know when they're doing things that actually help. I mean, if all we do is measure processes and inputs, then we don't know if the efforts of our team are really achieving better results for our patients. So you have to measure results. And in order to do that meaningfully, you have to know what segment of patients you're serving, because the outcomes that are important for one group of patients may be very different from the outcomes that are important for another. Right? So, if what you're worried about is prostate cancer, you're going to be worried about impotence and incontinence. But I don't want my dental surgery judged by whether I'm incontinent afterwards, right? Doesn't make any sense. Dentists just shouldn't be that scary. But if you think about it, you're going to need different outcomes for different segments. And so you're going to have to be organized around segments. That's a tall order for hospitals and for healthcare delivery systems. So let me turn this inside out for a minute and show you. In the work that we've been doing on value-based healthcare, from redefining healthcare and 10 years of work on implementation following that, the frameworks that we use to help organizations are essentially the inverse of this. We start with groups of patients and solutions and kind of move up to payment. So let me show you. This is the way we would normally work on it when we're working with providers. So we say, look, you've got to start with patients and families who have shared medical circumstances. So if you're thinking about how do we create excellent care for patients with back pain, that's going to be a different project than how do we create excellent care for kids with asthma. Obviously, but you have to think about the big segments that you're serving and think about what does it mean to achieve excellence there. So you start thinking about, so what's a solution need to be for a family with a kid with asthma? What needs to be included in that so that the kid isn't a frequent flyer in the emergency room and can play and lead the normal life that you would want the any kid to be able to lead? Once you understand what solution you're aiming for, you can think about who's on that multidisciplinary team and how do we actually deliver this solution, and what outcomes are we measuring to make sure that we're improving the lives of those particular patients and those families. That allows you to get to the point where you can have aligned payments. You can create different kinds of partnerships, because you can say, for your employees with back pain, we're offering a different kind of solution. You can say, for your employees with type 2 diabetes, we're offering more effective care so they won't end up with kidney failure. They won't end up with amputation, or at least not to the degree they do now. And then from there, you can think about, what does this mean for creating a rational, well-functioning system? And then, how do you grow based on value rather than growing just based on volume? And so this is the agenda that we're taking the organizations that you're working with and selling to through. And this is where the leaders who are defining the new frontier, these are the things that they're thinking about. So and then, of course, as you go through this, you find that there's an evolving information supply chain. You can't just put IT in place and hope that'll fix everything. It doesn't. The IT systems now, unfortunately, are mostly built around billing rather than how do we make the doctor's life easier? How do we make the nurse's life easier? How do we make the outcomes better for patients? That would be a whole new kind of IT. So one of the things that I wanted to share with you based on the conversation you were having this morning is what we've been doing in terms of what we call experience groups. These aren't focus groups, but they are groups of patients with shared medical circumstances. And we bring them together to talk not about their medical care, but about their life with the condition that they face. So we may be talking with people who have type 2 diabetes, or we might be talking with people who've survived colon cancer, or we might be talking with women who have breast cancer, or people who have congestive heart failure, or who are at high risk for heart disease. Different segments. But we bring together people who have shared medical circumstances, and we get them talking to each other about the barriers to and enablers of success in life with their medical condition. We have so many people who are viewed as non-adherent, non-compliant, or who are pursuing care that doesn't work for them. What's really going on in people's lives? And they tell us things that that they would never tell their doctors, but they're talking to each other about how they make their life work. And some of the things are very, very easy to fix. Some of them are harder to fix. But for example, we were working with one group. Everybody who'd been given to us had been branded non-adherent by their doctor, but they didn't necessarily know that. They were in this group talking about managing their diabetes. Most of them were nurses because they were hospital employees, and people were not taking their insulin at work. Okay, they're nurses. They understand what the disease is about. They understand it's important. They're on a 12-hour shift, so they know they have to, what's going on here, right? And the notion that people who are non-adherent are just lazy really just didn't fit with what we were observing. So we got them talking, and when they talk, what comes up is, well, there are no sharps boxes in the restroom at work, and if I take a used sharp out in the hallway, I can lose my job, and I absolutely can't afford to lose my job, so I wait to take my insulin until I get home. What? Really? It took 48 hours for that organization to have sharps boxes in every bathroom, right? But you don't go into your doctor and complain about your employer if you're afraid you're the only one. So people don't ask for what doesn't exist, and the point of what we're working on here is to identify non-existent services, unmet need, unarticulated needs that patients have in a particular segment. And we learn all kinds of stuff because you don't go to the person who did your back surgery that helped, or who helped you to survive cancer and complain about stuff that sounds small. And so, but there are all kinds of things that we can do better and we can help with if we can articulate the needs in the first place. So this is one of the things we've been working on, and we get 3 things out of it. The first is you pull people together, and if the conversation goes well and they share outcome measures that they're really functional, capabilities that they want to be able to have, if there's a small set of those things that they have in common, then you've got the segment right. And if they're having trouble having the conversation about what's most important to them, you haven't got the segments right. So first thing it does is give you a check on the segments. Do you understand how to create patient segments rather than just how to create hospital departments? The second is that it helps you identify really meaningful metrics. So in our work with patients with type 2 diabetes, one of the things that we didn't hear was when we were talking about what are you really concerned about in terms of your life and your capabilities and your medical risks, no one brought up kidney failure. No one brought up kidney disease. It's not that it's not important, it's really important. But it's very clear that it's not the place to start if you want to motivate those patients. It's not what they're worried about now. They're worried about, can I use my feet? Can I take my grandson hunting? Can I dance at my daughter's wedding? Can I walk my child to school? They're worried about use of their feet. They're worried about eyesight. Can I read? Can I drive? Can I shoot? They're worried about eyesight. And they're worried about erectile dysfunction. Can I make love to my wife? Those were the big things that came up for people with type 2 diabetes. And so if you design the care so that the motivation starts there, you reach more people much faster. And then we also then develop insight on these invisible unmet needs and can design things into the services that need to be there. One of the guys who designed care for frail elderly in a very successful way on the East Coast was saying one time, the thing is, we all think we have to coordinate care, but that's not an answer because you can't coordinate services that don't exist. You got to first figure out what needs to be included and then create integrated care. So what's this mean for you guys? Well, when you're thinking about payers and networks, what we're seeing is that employers care deeply about functional outcomes. Can you go to work? Can you lift the things you need to lift at work? They care deeply about functional outcomes, and they care deeply about having their employees pleased with the functional outcomes of their medical care. And employers are beginning to embrace bundles, particularly where they know that it's associated with better functional outcomes for their employees, and then more certainty about what they'll have to pay. The concerns that they have about travel, but do I need to ask my patients, my employees, to travel for excellent outcomes, mean that networks and affiliations are more critical. And I think that's really important for you guys because teaching makes those affiliated providers have more consistent outcomes. So when you think about Cleveland Clinic is world-renowned in heart care, but there are Cleveland Clinic doctors doing heart surgery in 9 states in the US. Cleveland Clinic employed doctors doing heart surgery in 9, so it's not all in Cleveland, and it's not all, there are Cleveland Clinic facilities in Ohio and Florida, but there are 7 other states that have Cleveland Clinic doctors because they can teach the processes and share outcome metrics and show that if your surgical team becomes a Cleveland Clinic team, you can demonstrate better outcomes for your patients. And so people want to affiliate. So the education about what is a really good care path and how you do it and how you use the right devices and how you use them well is really, really important to enabling this network expansion. And increasingly, you're seeing the adoption of supplies, devices being done by groups, by networks, by consortia. And so having your message right is becoming less and less doctor by doctor, surgeon by surgeon, and more frequently across a larger group. So more impact for the effort that you put in. In terms of the providers, the Value for patients means that you have to segment so that you can talk about value. You can't talk about value at the level of a hospital or a health system. If you could, it would be, because you wanted to check into the hospital for a weekend. You can't talk about it at that level. You have to talk about it at the level that we actually help people improve health. But reorganizing around the patients, being truly patient-centric, is a really tall order for change. So the providers that you're working with are really looking for help with this. You need to be able to demonstrate how you improve outcomes and how you reduce costs. And as they build these integrated practice units, these teams, they become better and better partners for you in demonstrating the value of your services and your devices. If you think about it, if you're working with an excellent team, if you're working with a team that has less variation in their outcomes overall, then the differences that you make are easier to make clear. They're easier to demonstrate. You actually want to work with people on the frontier, and you were saying this earlier, work with the best surgeons. But it's not just the best surgeons. The data shows it's not the individual surgeon, it's the team. And when you have a standing team, you can push that team to even greater heights. So you can do things that help to create the opportunities. So your partnership with providers actually supports their efforts in value-based growth, not just volume-based growth. Think about what I told you about the Cleveland Clinic's Heart Network. So your expertise and your help to them in achieving excellence creates more opportunity for them to grow through value rather than just growing by brand. Standardized measures make your work on this easier. So when I showed you the picture from ICHOM, the International Consortium for Health Outcome Measurement, those are internationally developed and vetted measures around a variety of conditions. They're building out as fast as they can. But if people are measuring standardized stuff, then not only can you show that your team is improving, but you can also show how your team is doing relative to others in the field. And you can show that you are clearly above average, or you can show that you're clearly in the top 10%. Or you can see that you're really not, and maybe this isn't what you should be doing. We talked to somebody last week who'd been in charge of closing the congenital heart surgery services at a hospital after 7 deaths in a row made someone realize that those patients should be driving 30 minutes to the place that rarely had deaths. Sometimes it's about recognizing what you're not doing well. You want to help the providers understand how to communicate outcomes. It's not about communicating blood loss during surgery. It's about communicating stuff that we all get, that we understand, that it's clear to patients as well as to the clinicians. And for all the talk about outcome measures, really, you want the referring physicians to understand those measures. We're going to be at a point where referring physicians have more influence on choices than individual patients do for a long time yet to come. I mean, someday there may be, but think about, the communication to referring physicians. And then we want to be measuring positive outcomes during the experience. We want to get beyond safety, which is critical but should be de rigueur, and beyond satisfaction. Right? I mean, think about it. Service satisfaction. It means different things in different places, but it's not the most important thing in healthcare. The question isn't, was the parking great? And it shouldn't have to be, were people polite to you? They should be polite to you, right? We want to get beyond satisfaction. We want to get to what satisfaction's really about in healthcare. I mean, Six Flags has a service business, but what's really great service there is a wild ride. You don't want that in healthcare, right? Your favorite pub is a service business, right? But what you want to do there is while away the hours. Not in healthcare, right? So if you think about it, different services have different things that are important about them. And so we can't just ask for net promoter scores, which is really what everybody's been driving to recently. You get through a life and death, it's major surgery, you're going through something, and at the end of this, or even in the middle of this, your healthcare provider comes to you and says, so, how were we? Wait a minute. This is healthcare. That's actually not the right question. I mean, it's a reasonable question, but it's not the core question. The core question is, how are you? Because it's healthcare. And we can figure out how we did by aggregating across what's essentially answers to the question, how are you? That's the perspective we want to be taking. So if we're going to ask, how are you, then we have to get more specific, right? So what matters to patients? Well, it's quality of life and dignity of death, but isn't that vague? So what we do when we're working with groups on this is we have them look at three things. First is capability, functional outcomes. Can you walk? Can you lift your child? Can you go to work? Functional outcomes that we all understand. The second one is comfort. Are you in pain? Is the disease itself causing angst? If somebody tells you you have cancer, that does cause angst, right? Can we reduce that angst? Can we help you with how you're going to give this news to your family? That could reduce that angst. And then calm. Less burden of the treatment, which actually, that's one that you guys are doing a lot on, right? But most places don't think about this measure or don't think about it carefully enough. Healthcare, a big healthcare experience, creates mayhem in the family's life. And frankly, also at your workplace usually, right? Creates mayhem. So what we want is to think about how do we have less time spent, less invasion into your daily life, less mayhem. So let me explain really quickly how this plays out when you think about it, because people will say, yeah, we've heard all this stuff about outcomes, but patients don't really listen to them. In fact, I'm not sure referring doctors really listen to them. So, how are we going to get over that hurdle? If you measure what really matters, people hear you differently. So these are measures. This is from Germany. This is ICHOM data, the consortium I talked about before. And this shows you the best place and the average hospital in Germany for prostate cancer surgery, for advanced prostate cancer. There's no difference, right? There's nothing here that you would do anything about or make any decisions based on, right? But if we talk about functional outcomes, not will you live for 5 years, but how will you live for the next 5 years, it becomes a lot clearer. If you go to the best place, you have a 17% chance of being impotent. On average, a 75% chance of being impotent. That's a meaningful difference, and people get what it means. Incontinence, less than 10% chance at the best place, over 40% on average. Where do you want to go? When you have meaningful, clear, functional outcomes, people listen differently. And this place is now doing enormous amounts of surgery. These are our MD Anderson's chart on this is for prostate cancer. At MD Anderson, if you look at this in a multi-dimensional way, what you see is that, well, it's more expensive. They succeed best for you on most dimensions, not quite all, but most dimensions with proton therapy. But you can use this kind of analysis to say, type of treatment A, type of treatment B, type of treatment C, and compare them. Or you could look at surgical team A, surgical team B, surgical team C, or device A, device B, device C, but you can compare different approaches or different places with this kind of multidisciplinary approach in a way that people understand. So back to back pain, it would look like this, for example. So if you were comparing approach A and approach B, or device A and device B, you might have one that's lower cost but not achieving better outcomes, equal or worse outcomes, relative to something that is potentially newer, currently higher cost, but getting better outcomes on other dimensions. And you could have the discussion about which approach do your patients need. So you can have it in a very, you can have these discussions in a very down-to-earth way. So as you make this transformation from volume to value, the really critical thing in getting things moving is measuring outcomes, measuring capability, comfort, and calm. Because what you don't measure won't improve. If you don't measure it, you can't manage it. So it's important to measure what matters. And what that means in healthcare, essentially, is we need to change the perspective from asking, how much have we done, to how are you? And if we do that, we'll drive the needle on that so that more people can answer that question in the most positive way. Thank you. Sit.
Very good. Thank you very much. Well, Elizabeth, thank you very much. We're going to take a few minutes just to ask you some questions and elicit some from the audience as well. Let me ask you the first one here. As we think about this transition from volume to value, what's most going to drive that transformation? Is it a regulatory backdrop, or is it just the willingness of the providers and the other players in the ecosystem to go there? What's the inertia right now, and what's the motivating factor in the future?
So it's a combination of things. The best thing that the regulatory agenda could do would be to require measurement. Mm-hmm. And right now, if we just rewarded participation in meaningful measurement as opposed to rewarding people actually for their outcomes, we'd get more movement. But really, it's going to take change at the provider level, mm-hmm. and it's going to take, for them to do that, it's going to take support at the supplier level, drugs and devices and IT systems. Mm-hmm. So it's going to be a combination.
And are you encouraged or discouraged at the pace of change going from volume to value right now?
Right now, I'm really encouraged. I came into this, I didn't expect any change to come out of this work when I was doing it. Mm-hmm. I didn't anticipate any real change coming out of it. I just couldn't sit still after what we'd been through. Mm-hmm. And Uwe Reinhardt, who's one of the big names in healthcare economics, immediately published something that said, this is a utopian vision. It would be wonderful if healthcare were about value for patients, but that won't ever happen. And he's actually come back and said, you know what? Maybe it will, which is really a fabulous thing to see going on. And so now, with Medicare saying, no, we're going to try to pay around bundles. We're going to try to align payment. We're going to try to track functional outcomes. And with international movement to create shared outcome measurement, I think we're going to get over the hump. And not tomorrow, but I think we're going to get there.
And I hate to put timeframes on anything, but when we say get there, is it end of the decade? Is it 10 years from now? Or give us some sort of context of when we might see this be more mainstream.
Right. So I think it's going to be very uneven. So healthcare isn't one thing. It's many things, depending on what the conditions are. And some of those areas are way ahead of others. So, there was meaningful measurement in heart surgery 20 years ago. Mm-hmm. But there hasn't been meaningful measurement in some areas of care yet. Mm-hmm. So it's going to be very uneven. With some of the groups that we're working with, they're already pushing the frontiers in remarkable ways. We're seeing major change in primary care as people start to realize that you can't provide good primary care absent behavioral health support. Mm-hmm. Some of the estimates are 80% of primary care visits are motivated by behavioral health issues. 80%?
Wow.
Holy smokes, right? So, people are seeing those things and going, well, wait a second. If I have to be responsible for financial risk, then I got to understand what actually drives it.
The outcome measurements you had put up on one of your slides about capability, comfort, calm, resonated very much with me relative to spine, as you said. Could you perhaps share with us if there is one that's most advanced on thinking about the use of some of those outcome measurements and how they've applied them?
Right. So it seems to be different in different areas. So orthopedics has always been pretty good at functional outcome measures. A lot of neuro is good at functional outcome measures, meaningful ones. We get into problems when you have some 20-page form that somebody has to fill out to show function. I mean, really the most meaningful metrics are really pretty easy. And when we ask questions like, could you go to work? You actually know the answer to that in a pretty reliable way. You know whether you went to work or not. And it tells us a lot about how healthy you are. So some of those areas, in terms of comfort, there are areas where measuring pain is normal, right? And so you've been given those little smiley faces that range from the sort of grimacing monster to the great big smile on pain. We don't need to be able to compare your pain to mine. We just need to know whether the help that you're giving me reduces my pain.
Right.
Same with anxiety.
Right.
And so there's a lot of, and then on calm, it's really interesting. Home care has thought a lot about it because that's what they do, right? Home care is trying to create calm in people's lives. Hospitals are measuring things like number of quiet hours at night.
Right.
They're fairly simple things, but they really, from what the conversations I had this morning and at lunch, you understand more about your patients in terms of capability, comfort, and calm than most of the providers I work with understand about the same sets of patients. They're desperate for help on that stuff. I think you guys could help them to see how to demonstrate the value that you create and they create.
And I think the good news story is that relative, I suspect, to a lot of the data collection and analysis we've done historically about minimally invasive surgery, what you've just described in terms of smiley face or monster face, I mean, this stuff is relatively straightforward and could get going pretty fast, like really fast.
Really fast, right. So
and have an impact.
So it's at Cincinnati Children's, they were, so this is pediatric, psych, outpatient, patient reported, I mean, all the things that people say make it difficult. But their team wanted to figure out, how do we really improve care for kids with OCD? So they had this form that took over an hour for people to fill out. You can't do that at every visit. You can't do that even in one visit unless it's a special visit. So they created this new form. And the new form has 4 of these sets of grimace to smile on can you do your homework? Can you play with other kids? Do you feel like the disease is in control or you're in control? I forget, but 4 of them. And the kids filled them out every time they came in. And within a matter of months, they could see which kids were getting out of the diagnosis quickly, figure out what was being done differently for those kids, and apply it. And so very, very quickly, they took the time that it takes to get a kid out of that diagnosis cut about in half. Many fewer families were leaving the practice because it was working. And then at the end of their study, they went back and used the long form and validated that, yes, in fact, these kids were out of the... So they put this stuff together with incredible speed. And you can imagine the satisfaction of the team that was involved in that.
It's a little bit like what Jeff Dyer showed on the Intuit tax thing. I mean, just make it simple, make it accessible, and then it can have impact and success. So...
yeah, imagine if we tried to make health easy.
Oh, I agreed. Totally agree on that. Well, listen, Elizabeth, thank you very much. It was very fantastic and very helpful for all of us. We'll give her a round of applause. Thank you very much.